Imagine for a moment your father-in-law comes up to you and tells you how his life changed when his father was diagnosed with Alzheimer's disease, how he slowly drifted away to the point he didn't recognize his wife and kids anymore, to the point where he himself was unrecognizable, becoming a hollow representation of his father. Now your father-in-law looks right at you and tells you he was just diagnosed with Alzheimer's disease. He pleads you to help him. What would you do? Good morning, ladies, gentlemen. I'm honored here to speak to you this morning, this time about the results of following a hint or gut feeling, thinking out of the box in an outright for transdisciplinary approach to adopt novel therapeutic strategies. Alzheimer's disease prevalence is increasing rapidly in the absence of truly effective therapies. This time, the patient was someone really close to me. I present you the case of a 69-year-old retired white man with college-level educational background. The patient presented cognitive decline with short-term memory impairment, occasional spatial disorientation, insomnia, misplacing common daily life objects, and mood changes. Relevant data from his family history reveals his father had late-onset Alzheimer's disease, first-degree relative with renal adenocarcinoma, pituitary macroadenoma, systemic arterial hypertension, and type 2 diabetes. Due to his growing cognitive impairment, the patient was evaluated by a geriatrician, Dr. Sobranos, who diagnosed Alzheimer's disease with a mini-mental state exam of 24 hours of 30, clock drawing test, and MRI to rule out other causes of dementia. No genetic testing, serology, nor functional imaging were performed. After a careful thought and preparative evaluation, he was admitted to a hospital for an intestinal tract departition. Transient departition is a simple yet powerful novel metabolic surgery for type 2 diabetes management. It involves the creation of side-to-side anastomosis in the jejunum to the ileum in order to enhance L cell secretion. L cells produce syncretins such as GLP-1, glucagon-like peptide 1, glucagon-like peptide 2, peptide YY, oxyntomodulin, and others, while preserving ghrelin secretion. As opposed to bariatric procedures, transient departition is neither restrictive nor malabsorptive. It enhances enterohormonal production in order to optimize insulin secretion. Yet incretins exhibit pleiotropic actions such as neuroprotection and neuroregeneration. To the best of our knowledge, ours are the first patient in which PTI or any metabolic procedure is being tested to define their potential role in neuroregeneration. These are some of the effects of incretins in the central nervous system, and how incretins reduce neuronal apoptosis through caspase, through GSK3B, nuclear factor kappa beta, mTOR, and FOXO1. After the procedure, the patient recovered uneventfully and was discharged home on postoperative day 2. His evolution has been remarkable. At 3 years after surgery, his mini-mental state evaluation is 23 out of 30, reducing a total of a single point in 4 years after diagnosis. His clock drawing test still scores 9. This behavior is significantly better than slow progressors who would have declined by this time an average of 3.2 points in the mini-mental state examination. His treatment remains unchanged, taking memantine 5 mg twice a day and transdermal rivastigmine 4.5 mg. Unfortunately, there were 2 adverse events. First, he developed hypoalbuminemia with 3.2 gram deciliters that was reversed with diet alone. No other signs of malabsorption or malnutrition have ever been noticed before or afterwards. There was an event of adhesive small bowel obstruction that required surgery, after which he recovered again uneventfully. This is a comparative imaging from the clock drawing test. In the right side of the screen, there's our patient's clock drawing test. the patient still is an independent and productive member of society. Why is it that metabolic surgery might help within this context? Type 2 diabetes shares some metabolic pathways with Alzheimer's disease, including impaired insulin responsiveness, insulin desensitization, low-grade chronic inflammation, fewer glucose transporters at the blood-brain barrier, endoplasmic reticulum stress, and similar microbiomal profiles. Brain insulin resistance, a common early feature of Alzheimer's disease, is closely tied to cognitive decline and capable of promoting many biological abnormalities. The proximal cause appears to be neuronal elevation of serine phosphorylation of IRS1, most likely due to amyloid beta trigger microglial release of pro-inflammatory cytokines. Due to the similarities, some authors might refer to Alzheimer's disease as type 3 diabetes. Type 2 diabetes as Alzheimer's disease involves increased oxidative stress, low-level inflammation, and autophagic dysfunction, increasing the position of abnormal proteins like amyloid beta, tau proteins, and neurofibrillary tangles, thus producing synaptic dysfunction and neuronal loss. Other events in Alzheimer's pathology include mitochondrial dysfunction, increased apoptosis due to activation of cytochrome C, caspases 3 and 6. Interestingly, there are some largely unknown interactions with the gut microbiota. Microbiota in Alzheimer mostly lack the organisms responsible for butyrate and propionate production, release fewer short-chain fatty acids, increase lipopolysaccharides involving chronic inflammation, and even bacterial amyloid beta-like peptides. Alzheimer's and type 2 diabetes share physiopathologic pathways as well as preventive measures such as physical exercise, Mediterranean diet, anti-diabetics, and even surgery. This fact prompted us to consider the hypothesis of utilizing metabolic surgery to change the natural history of Alzheimer's disease, as we could start to see with Parkinson's disease. But how? Metabolic surgery is the best treatment for managing type 2 diabetes. It enhances GLP-1 production, inhibiting beta cell apoptosis, including inducing pancreatic islet neogenesis and increasing satiety. This in turn favors glycemic control and induces insulin responsiveness. The GLP-1 axis. GLP-1 is an enterohormone that is produced by the L cells in the distal ileum. DPP-4, or dipeptidyl peptidase 4, destroys GLP-1 and inactivates within 2 to 5 minutes. DPP-4 inhibitors are used as anti-diabetic drugs. So the repurposing of anti-diabetic drugs for the modulation of brain insulin resistance in Alzheimer's disease appears to be of great interest. The beneficial effects of synaptogenesis, neurogenesis, and cell repair, as well as the reduction of the chronic inflammatory response, and most importantly, the reduction of amyloid plaques in the brain, indicate that these drugs might promise as novel treatment for Alzheimer's disease. DPP-4 inhibitors enhance serum levels of GLP-1 and gastroinhibitory peptide or glucose-dependent insulinotropic peptide (GIP). They favor improvement in cognitive impairment clinically, reduce pro-inflammatory cytokines, and increase anti-inflammatory factors. Through the same mechanism, they decrease plaque load and apoptosis. Clinically, they even improve many mental state examination. Other strategy, GLP-1 receptor analogs, restore glucose transport at the blood-brain barrier and normal brain insulin responsiveness, reduce plaque load, decrease tau phosphorylation, thus reducing neurofibrillary tangles, neuroinflammation, caspase activation, and neuronal apoptosis. But they also increase synapses and ameliorate learning and memory impairment. GLP-1 receptor analogs may be quite expensive in some countries, and typical Alzheimer's disease patients are retired and might not have access to this type of medication, especially when using it outside the intended indications. Dual analogs GLP-1, GIP, and even triple analogs GLP-1, GIP, and glucagon seem to have more profound effects in neurogenesis and microglial inactivations. They reduce inflammation, oxidative stress, and like tau phosphorylation. They are anti-apoptotic. They protect memory formation, improve hippocampal synaptic plasticity, and enhance synaptic activity and numbness. Bile acids are cholesterol derivatives better known for their digestive role, although they present potent anti-apoptotic and even neurodegenerative potential. A secondary bile acid, tauroursodesoxycholic acid, prevents plaque deposition, lowers level of amyloid beta 140 and 142, reduces endoplasmic reticulum stress, neuroinflammation, and apoptosis. It has been shown that TUDCA increases dendritic sprouting. Surgery favors increasing bile acid concentration and favors also shifts in the microbiota. In Alzheimer's disease, there is a decreased firmicutes population and increased bacteroidetes. These hallmarks are similar to those observed in patients with obesity and type 2 diabetes. Surgery and diet might model microbiota promoting butyrate and propionate producing bacteria, increasing serum levels of primary and secondary bile acids, and enhancing GLP-1 production. By modeling microbiota, there were some effects in cognitive decline. And as you may see, there are profound changes in the microbiome in patients before and after surgery. During the last 30 years or so, drug development for Alzheimer's disease has been focused on those hallmarks described by Alois Alzheimer: amyloid protein level and tau phosphorylation with model results. Neurodegeneration will become a profound healthcare problem as foretold by epidemiologic studies. As with other neurodegenerative disorders, endoplasmic reticulum stress, mitochondrial dysfunction, and subsequent synaptic loss are associated with a more evident and prevalent features like obesity, metabolic syndrome, and diabetes. Some authors have proposed the term type 3 diabetes to better characterize metabolic derangement in neuronal physiology present in Alzheimer's. So reducing stress of the endoplasmic reticulum, preserving mitochondrial function, and favoring neuroprotective and neuroregenerative events becomes a plausible option. GLP-1, glucagon, and GIP enterohormones have shown to promote synaptic sprouting and neuronal regeneration. Changes in gut microbiome reduces pro-inflammatory insults, and enhancing bile acid concentration has also been associated with anti-apoptotic properties. All these events are some of the beneficial effects produced by metabolic surgery. So, metabolic surgery might provide a simple, novel strategy to be studied in this context. What does it mean? At the end, it means hope. Hope for a better future, hope to change people with Alzheimer's disease. So, by now, if your father-in-law comes to you and asks for your help, would you do something different?